Welcome back to the deep dive. Today, we're getting into the science behind a condition that, well, a lot of people just call it the dandruff that won't quit.
Seborrheic dermatitis, or SD for short.
Exactly. And we have pulled together a pretty comprehensive stack of sources to try and solve this really persistent and often frustrating skin puzzle for you.
It really is a classic. It's a chronic inflammatory skin condition. And I think understanding it is really the key to managing it.
So what are we talking about here, symptom-wise?
We're talking about persistent redness, some itching, and scaling that specifically targets areas of the body that are rich in oil glands.
Okay, so the scalp, the face.
Right, the scalp, the face, particularly around the nose and eyebrows, and even the upper chest. It's important to establish right away that SD is non-contagious.
But it is recurrent.
Oh, definitely recurrent. And that's why it can be so annoying for people dealing with it.
And I think that frustration also comes from just misidentification. Our sources really highlight that people frequently confuse it with just, standard dry skin.
Or they think it's common eczema, or even psoriasis, because the symptoms can overlap quite a bit.
So our mission today is to distill the complex root causes so you know precisely what you're dealing with, and, maybe more importantly, how to interrupt that cycle.
To really get to the root of the problem, we have to look at SD based on its two core characteristics.
Yeah.
One is inflammation, and the other is the excessive production of sebum.
Sebum being our natural skin oil.
Exactly. Visually, SD shows up as persistent scaling and plaques. But unlike, typical dry skin flakes, these often have an oily or even a yellowish appearance.
And that's on top of the redness and the itching.
And often very intense itching.
Okay, let's unpack this a little. Why is the skin suddenly making too much oil and getting inflamed and scaly all at once? It seems counterintuitive.
It does. And it's not just a hygiene issue, which is a common misconception. There's a critical internal trigger at play here.
And this is really the central nugget of knowledge, isn't it? The whole condition is driven by an abnormal immune response to an organism that, well, it lives naturally on everyone's skin.
That's it. That organism is a type of yeast called Malassezia.
Malassezia, okay.
And this yeast is lipophilic, which is just a scientific way of saying it absolutely loves fat. It thrives where that sebum is plentiful.
So think of it like a fungus living on an oil slick.
That's a great analogy.
Yeah.
And the mechanism is basically a chemical chain reaction. When the yeast consumes that excess sebum, it metabolizes the oil into these irritant fatty acids.
Ah, so it's the byproduct that's the problem.
It's those irritating byproducts that trigger the disruption of the skin's protective barrier, and that's what sets off the whole inflammatory cascade.
So the body sees what the yeast leaves behind as a foreign invader, and it mounts this inflammatory response that causes all the redness and the scaling.
Precisely.
So if the condition is fundamentally a reaction to a fungal presence, that makes the treatment approach immediately clearer.
It does. We often classify SD as a fungal-driven condition,
Right.
but we can't forget that this whole oil yeast battle is influenced by other things. It's not just about the yeast population. It's about how your immune system reacts to it, which brings in factors like, say, genetic predisposition.
So some people are just wired to have a stronger, more visible reaction.
Exactly.
And what about systemic issues? Our sources mentioned neurogenic influences and endocrine imbalances. Are those involved too?
They absolutely are. It's about susceptibility and severity. The influence of hormones, that's the endocrine part, directly relates to sebum production. Hormones regulate oil.
Okay, that makes sense.
And the neurological component suggests a link between the nervous system, stress, and these inflammation pathways in the skin. So this really isn't just a surface problem.
It's more of a systemic vulnerability that determines when and where that Malassezia yeast is going to gain the upper hand.
You've got it. And given that oil is the absolute fuel for this condition, the anatomical regions it affects are, well, totally predictable.
So where do we see it most?
We see it on the scalp, the nasolabial folds.
Those are the creases from the nose to the corners of the mouth.
Yep. Also the eyebrows, behind the ears, the chest, and sometimes right in the center of the forehead.
Right.
Anywhere you have high sebaceous activity is a potential flare-up site.
Let's dive into what this actually looks like, starting with the area most people think of, the scalp.
Okay, so on the scalp, it can look like just generalized dandruff, but it's often, greasier flakes, itching, and these inflamed patches.
And what's fascinating is the variation in how it presents, which I guess reflects the stage of the inflammation.
That's right. If you see active redness, That's signaling blood flow and intense inflammation.
And what about the color of the flakes or scales?
Well, the white patches are just desquamated keratinocytes. That's just shedding dead skin. But if you see yellow crusts or scabs, that usually means oxidized sebum and dead skin cells mixing together.
That yellow waxy look is a pretty strong indicator of the oil component of SD then.
A very strong indicator.
Then we move to the face. When people talk about facial dandruff, this is what they mean, right?
This is it. It loves the P-zone. Eyebrows, sides of the nose, those creases. It often appears as yellow or white crusts sitting on top of red, inflamed skin.
And because of that redness, I imagine it gets misdiagnosed.
All the time. As rosacea or even just a simple contact allergy. The nose specifically has such high sebaceous density that it's a major flare-up site.
And the lesions there can vary.
Dramatically. Sometimes it's dry, powdery flakes, and other times it can shift to these thick, greasy crusts. It really depends on how active that microbial load is at that moment.
This brings up a really important comparison. The link between adult SD and cradle cap in infants, we've all seen it, that thick, yellow, scaly patch on a baby's scalp. Is it the same thing? If they share the same root cause excess oil and Malassezia yeast, do we treat them the same way?
That's a crucial question. And the answer is, sort of. They share the same microbial roots, yes. But the timeline is totally different.
How so?
Cradle cap is largely triggered by an influx of maternal hormones passed during pregnancy, which temporarily overstimulates the baby's oil glands. But it's self-limiting.
It just goes away.
It typically resolves within a few months as those hormones clear the system. Adult SD, on the other hand, is influenced by long-term hormonal changes, genetics, stress.
It's a chronic, recurring condition.
Exactly. It requires ongoing management. It doesn't just go away.
So if you're trying to figure out if your persistent flaking is SD or something else, let's run through the full range of symptoms from our sources.
Okay.
Beyond the dandruff and itching, you should look for redness from that increased blood flow, thick, scaly patches on oily zones, and crusting.
Crusting being that hardened, waxy layer of oil and debris.
Right. And also sensitive skin that might feel like it's burning or stinging, even if you're not scratching it.
And because SD is such a great mimic, it's vital to know how it differs from its inflammatory cousins. Let's start with SD versus contact dermatitis.
Oh, wait, CD.
This is the difference between an internal cause and an external one. SD is caused by the interaction of your oil, your immune system, your yeast. It's an inside job.
Whereas contact dermatitis is from something outside that touches the skin.
Precisely. A new soap, a perfume, a piece of jewelry.
So if you change laundry detergent and get a rash on your wrist, that's CD.
Right.
But if you've had the same shampoo for 5 years and suddenly your scalp and T-zone are greasy and red, that points much more strongly toward SD.
Exactly. CD shows up where the irritant touched. SD requires managing oil and yeast. CD requires removing the irritant.
And the other big confusion point is SD versus eczema.
Ah, yes. While both are inflammatory, the defining feature of SD is that greasy yellowish scale and its strict adherence to those oily sebaceous zones.
Scalp, nose, chest.
Right. Eczema, on the other hand, is an immune-driven condition linked primarily to allergies, very dry skin, or general environmental irritants.
So eczema is more about a broken skin barrier that leads to water loss.
Exactly, which is why it presents as dry, red, intensely itchy patches that can appear anywhere, even non-oily areas like your elbows or the backs of your knees.
So bottom line, if you find thick, waxy, yellow patches on your eyebrows and scalp, it is almost certainly SD. Widespread, extremely dry, thin, red patches all over. More likely eczema.
That's a very good way to put it.
All right, this is where it gets really interesting for me. Once you have that predisposition for SD, certain factors can act as absolute flare-up fuel.
The perfect storm triggers, you call them.
The sources detail things like high stress, which affects hormones and the immune response, cold or dry weather, which damages the skin barrier,
and harsh topical products, especially those with high levels of alcohol, fragrance, or strong surfactants that strip away your protective oils.
And you have to mention the surprising link to underlying medical conditions.
You do. The sources show a higher incidence of SD in people with neurological disorders like Parkinson's disease and immune-related conditions like HIV.
Which really shows this isn't just a cosmetic annoyance. It's a symptom of a deeply interconnected system. This naturally leads to the question about hygiene, which often carries a lot of, social judgment. Can poor hygiene cause SD?
Our sources clarify this perfectly. Poor hygiene is absolutely a factor that can cause SD to worsen.
How so?
By allowing oil, debris, and dead skin cells to accumulate, which directly feeds that Malassezia yeast population.
Okay, so it fuels the fire.
It fuels the fire, but it is not the root cause. That's tied to genetics, immune response, and hormones. Regular cleansing is a necessary management tool, but even with impeccable hygiene, you might not prevent a flare-up during a stressful period.
Speaking of management, let's talk diet. This might surprise a lot of people.
It does. We usually think of diet affecting our gut, but specific foods can definitely influence sebum levels and inflammation.
What are we talking about here?
We can classify the problematic foods into two main groups: those that cause insulin spikes and those that promote inflammation.
So refined carbs and sugar.
Exactly. White bread, milk, chocolate, soda, ice cream, they all spike insulin. And when insulin spikes, it can signal the body to increase sebum production.
So you're basically laying out a new buffet for the Malassezia.
That's it. The food doesn't directly feed the yeast, but it changes your body's chemistry to provide more food for the yeast. It's a critical distinction.
And the other group?
Inflammatory fats and oils. Think bacon, fried chicken, foods high in saturated and trans fats. They can increase systemic inflammation, making the skin more reactive.
The sources also pointed to certain dairy items.
Yes, particularly aged cheeses like cheddar and even soy milk in large amounts, because these can influence hormone levels and oil output in susceptible people.
It really just underscores the idea that a balanced, low-inflammatory diet supports the immune health you need to keep that yeast in check.
It all comes back to balance.
So now for the actionable solutions. We've established this is fundamentally fungal, so where do we start with treatment?
The treatment strategy has to begin with tackling the yeast and the inflammation. Medicated shampoos are your first line of defense.
And you're looking for active ingredients, things like ketoconazole, selenium sulfide,
Zinc pyrithione or salicylic acid. All are good, but using them isn't like using a regular shampoo.
Right, this is probably the most important piece of advice here.
It is. These aren't wash-and-go products. They need sufficient contact time with the skin.
How much time?
The source is stress usage 2 to 3 times per week, and you must leave the lather on the scalp or the affected area for a good 10 to 15 minutes before rinsing.
That contact time is what actually allows the active ingredients to penetrate and kill the Malassezia population.
Without it, you're not getting the full effect.
Okay, beyond the scalp, what about facial and body lesions?
We have tools for that too. Topical antifungals, for one. Our sources mentioned tea tree oil balm as an example. And for intense acute inflammation and itching, corticosteroids come into play.
But with a big warning label, right?
A very big one. Corticosteroid creams or lotions are essential for rapid relief from severe redness and itching, but they are strictly for short-term, sparing use.
They put out the fire, they don't cure the problem.
Exactly. Overuse can lead to side effects like thinning skin or rebound flares, so they have to be used judiciously.
So are there safer options for those sensitive areas, like around the nose and eyes?
Absolutely. Dermatologists often recommend topical calcineurin inhibitors for those areas. They are excellent non-steroidal creams that help regulate the immune response without the long-term steroid risks.
And we can't forget moisturizing.
Cannot. Since many of these treatments can be drying, you need a good non-comedogenic, fragrance-free moisturizer to help restore that compromised skin barrier.
So ultimately, long-term control really hinges on preventative measures.
It's a chronic condition, so management is the name of the game. That means proper skin hygiene with mild pH-balanced products.
And no scrubbing.
No scrubbing. That just makes the inflammation worse. It's also about actively avoiding those triggers you've identified, maybe even keeping a symptom diary.
Track your dietary or stress-related flare-ups.
And for those chronic, truly resistant cases, light therapy remains an option in clinical settings.
And we should provide some reassurance here. SD is not harmful, is it?
Not at all. It's chronic and it's frustrating, but it will not lead to permanent damage or scarring or hair loss if you manage it consistently.
We have covered a lot in this deep dive. The key knowledge nuggets we've extracted really confirm that this is so much more than just dry skin.
It's a complex interplay of an internal immune response and microbial overgrowth. That oil-yeast relationship is everything.
And that specific lifestyle factors, especially our stress levels and our diet, are major systemic triggers.
And we detailed how, even though it shares symptoms with cradle cap, the adult version is managed very differently. Adult management has to focus on that persistent microbial balance over the long haul.
It's not just about temporary soothing.
Not at all.
So what does this all mean? The complexity of SD lies in its identity as an internal, immune-mediated, and microbial skin condition. If you're struggling with persistent dandruff, understanding this holistic picture, that it requires diet and stress management alongside those targeted antifungal treatments, is your shortcut to getting it under control.
And here's a final thought to leave you with. If hormonal changes and neurological disorders like Parkinson's disease increase the risk of seborrheic dermatitis, what does the study of this common, everyday skin condition reveal about the overall, often overlooked interconnectedness of our skin, our nervous system, and our immune system? Think about that as you continue your own learning.